So hello everybody, I'm Markus from Bavaria in Germany, and I used to be a senior consultant for orthopedic and trauma surgery at the University Hospitals in Munich until 2017, and then I moved towards my hometown, Rosenheim. I'm there in private practice and specialized for foot and ankle surgery there for about 10 years now. So my talk will not be really very scientific. I just would like to give you a kind of overview of possible applications of the internal brace in acute trauma cases. And I would like to start with my specialty, the foot and ankle. So we have a lot of ligaments and joints in this area, so we really can brace a lot in this area, like you see in this overview. And the two main indications for me are the stabilization of the anterior inferior tibiofibular ligament and the anterior talofibular ligament. The other indications are quite rare compared to them. So sometimes still I do general trauma cases, and in these cases I like to use the internal brace for stabilization of the elbow, patella dislocations, or patella tendon, and of course Achilles tendon tears. And one special thing I would like to show you is the speed bridge technique, which may be a kind of an internal brace using for refixation of major tendon avulsions. So this technique I use for refixation of the triceps tendon at the elbow, for the proximal hamstrings, for the quadriceps tendon now, and for the Achilles tendon, of course. So let's start with the syndesmotic internal brace. We have published this technique in 2017, and we try to add more rotational stability to the stabilization of the syndesmosis by using an anterior internal brace. And I would like to show you this case. This is a type C ankle fracture with obvious medial instability. And first we performed a standard approach for plating of the fibular fracture. And after stabilization of the bony injury, performed the external rotation test for testing the stability of the syndesmosis. And this is what you can see. Even if the posterior syndesmosis is stable, only the anterior syndesmosis is torn, and you have this high degree of instability of the syndesmosis. And I really like this case to show that this kind of surgery can really be very simple and easy, but also very effective. Just repair what is injured, and if your repair is not strong enough, because the sutures of the ligament of the anterior syndesmosis usually not very strong, you can add stability using an internal brace, just bringing over the repaired ligament. So how can you perform this? I use a 3.5 swivel lock, fixing a fiber tape just at the fibular footprint of the anterior syndesmosis. Then I suture the ligament, and afterwards I put the tape over the reconstructed ligament and fix the fiber tape with a 4.75 swivel lock at its tibial footprint. It's just as simple as that. And what you see afterwards, you can perform the external rotation test again, and it's absolutely stable. The ankle has full range of motion, and you don't see any instability of the talus anymore. So I would like to show you my favorite case with this technique. It was an 18-year-old professional snowboarder who sustained a training injury after landing after a jump. And he got primary diagnosis, just a simple ankle sprain, and he got standard treatment using a brace, an external brace, for about 6 weeks, and physiotherapy. But about 3 months after trauma, he still was not able to perform exercises due to pain and feeling unstable. So when he came to me, the squeeze test and the cross-test sign were positive, indicating syndesmotic injury, which was confirmed by ultrasound and also by MRI and CT. In this kind of injuries, I like to use ultrasound because I can have a dynamic examination and test how stable the distal fibula is compared to the contralateral side. So this guy was stabilized with an anterior internal brace combined with a TightRope. And I would like to show you his rehab, which was really fast. He was allowed to perform full range of motion exercises according to pain immediately after surgery. And then 2 weeks after surgery, he started to perform really complex stabilization exercises I could not perform even without injury, I think. And then at 4 weeks, I have to start it here, he was able to perform running and skipping exercises. And here you should remember, patients getting standard treatment using syndesmotic screws, they are not allowed to bear weight for about 6 weeks after surgery, and this patient can run after 4 weeks. And 12 weeks after surgery, he was back on the snow again.
Oh my God!
Performing quite well. And so 1 year after surgery, he was able to perform at his pre-injury level, and he was able to take part at the Olympic Winter Games in Beijing. However, he was really unlucky there, and he injured his knee this time during the first competitions, but the ankle was still stable. So as syndesmotic injuries are often combined with the distal fibular fractures, about 2013, I started to combine this technique of anterior internal bracing of the syndesmosis with the plate fixation of the bone. And that time I used to fix the fiber tape underneath the plate I have inserted to fix it at the fibula. And I was really happy with this technique, and this got my standard procedure. So then I asked Arthrex if it would be possible maybe to put some eyelets into this plate for an easier fixation of the fiber tape in this technique. And Arthrex did, and so this new plate is available about 5 years ago now. And I show you one case with a type B ankle fracture with a bony avulsion of the anterior syndesmosis. So we plated the ankle fracture, and we refixed the small avulsion fragment with a small screw to its tibial footprint. But this refixation was not really stable, so I decided to add stability to this repair using the internal brace. And with this new plate, it was easy to insert the fiber tape through the eyelets and then fix the tape like you have seen before with the 4.75 swivel lock to the tibial footprint. So next topic would be the deltoid ligament. Again, a type C fracture with severe medial instability. And after having done the bony repair and the stabilization of the syndesmosis, I tested for medial stability. And on the right side, you see performing valgus stress. The medial side opens, and that's for me the indication to stabilize the deltoid. So this you can see here. You see the sutures for the deep deltoid, and also again putting fiber tape over the repaired ligament. This repair of the deltoid ligament, it is really very important that you exactly use the correct footprint of the ligament at the talus, so that you don't get a wrong movement of the ankle. If you put this footprint too far anteriorly or posteriorly, you would have a restricted range of motion. It's quite dangerous. The next example is a kind of shop parts dislocation. On the left side, you see the unloaded CC joint. Left bone is the calcaneus, right bone is the cuboid. And performing flexion and supination stress, the joint significantly opens, indicating an unstable injury. And also here it's quite simple to stabilize this joint with an internal brace. At this area, usually you don't have much tissue to repair because it's really thin, and in case of injury, all the tissue is gone. But you can use this internal brace as well. Next case is quite severe multifragmentary Lisfranc dislocation fracture of the fourth metatarsal bone. And I stabilized the fracture with a plate osteosynthesis. But after having the bone stable and moving the foot, the metatarsal still subluxated anteriorly because of the instability of the TMT joint. And again, to stabilize the joint, I used a fiber tape, put it underneath the plate, and fixed the tape on the cuboid bone with a 4.75 swivel lock. And so the joint was stable. And these are the CT scans. Here you can see the joint quite well aligned again. And the next case is a case of a severe forefoot injury with a subcapital serial fracture of metatarsals 2, 3, and 4, and unstable avulsion injury of the medial capsule of the great toe. So first we stabilized the metatarsal bones using antegrade intramedullary K-wiring, and then I tested the stability of the great toe, and that again was the reason to stabilize the medial capsule using an internal brace. So you see here on the left side, I drilled a hole through the bone of the base of the great toe. At the medial side, inserted the fiber tape there. Then got the two strands back over the repaired capsule and fixed the two strands to the metatarsal head with a 3.5 swivel lock. And as this technique works quite well, I am already using this technique also in a hallux valgus surgery, not in trauma cases only. And here you see the final result. So these have been my foot and ankle cases. And other trauma sites, I like to use the internal brace, for example, for stabilization of the patella. Maybe you know this technique already. I do not use anymore the gracilis tendon because it absolutely is not necessary to harvest this tendon. The fiber tapes work really well. And then I have one case which might be quite new. Because I did not find a similar case in the literature. I used the speed bridge technique for refixation of the quadriceps tendon to the patella. This was a 58-year-old man who fell downstairs and injured his, or avulsed his quadriceps tendon. And he was operated 2 times before, and all surgeries failed after beginning with the rehabilitation. So when he came to me, I tried to offer him a really the strongest refixation technique I knew. I had experience of fixation of the Achilles tendon to the calcaneal bone, which is really a stable construct. And I tried to bring this over to the patella now. So here you see the first thing I did, a radical debridement of all the soft tissue and scar tissue of at the site of the footprint, to have a bleeding bone surface there. Then I inserted 2 swivel locks with the fiber tape just close to the articular surface, and then brought the fiber tapes through the tendon from inside out, and then by bringing the tapes down to the patella, you can bring down the tendon to its footprint now. So I have a video showing that.
Yep.
Okay. And here again you see the necessary 4 drillings, the 2 drillings at the articular side, and then the 2 drillings at the anterior side. And in between these 4 drillings, here is the footprint for the tendon. We bring the tendon down here and fix it with the second row of swivel locks to the patella. So this is the final repair, and here you see flexing the knee. The quadriceps muscle is coming down nicely without any instability at the repair site. So this patient is really happy again, and this is also good for me because he's my tax consultant. So thank you very much for listening, and I'm happy to answer your questions.